get started. Thanks everybody for being here. I think we have, we already have 30 folks online, which is awesome. And so it's a real nice combination to have the online version as well as the in-person. And for those that are able to be here and see our really new, we think it's brand new, but now 7-month-old tuberculosis clinic with native blood rooms and everything. We've got both medical director of Hamilton County Public Health, Dr. Moises Mohammed, as well as medical director of Butler County Public Health, Dr. Lisa Hagan.
For the TV part.
TV program, yes, TV program, both for TV programs. I'm the medical director for Hamilton County Public Health. It's a great privilege to host here in a cool building and talk about the world's kind of oldest disease. In fact, Egyptian mummies, you can find tuberculosis in the bones. Woolly mammoths, you can find tuberculosis in the bones. Elephants have theoretically been sort of the carriers of tuberculosis through the years. In fact, our own zoo will do a quantiferon test on the elephants twice a year to make sure that they don't get that. And so it is an international disease. So much, in fact, almost all of active tuberculosis is actually from those who have picked that up at a younger age internationally and moved here. With the increase in immigration more and more every day, the incidence of picking up a latent TB infection is significant, even to the point where it's beyond really what your local health department can do by themselves. It really requires everyone, all clinicians, to have ability for both the adults and the pediatrics. We have format tonight, we'll have 2 speakers, one on latent TB infection in adults, and then one on latent TB infection in children, and then a very prestigious panel discussion, which will really be robust in terms of getting questions. We'll take questions from the Zoom. I do want to introduce Katie Gross, who is my boss, I guess.
I've finally acknowledged who really runs the show. Also would like to introduce our health commissioner for Hamilton County Public Health, Greg Kesterman, and our associate health commissioner on the clinical side there. So you guys will clap for anything. So without further ado, I'm going to just introduce as they come up. I want to start with our first speaker, who is Dr. Kelly McCollier Williams. Thank you. For latent TB infection in adults. She's a UC Associate Professor of Clinical Internal Medicine. She has infectious disease, a fellowship at UC Infectious Disease, as well as the residency in Internal Medicine at Indiana University, and is well known in the area of tuberculosis. For those who have the brochure, and I think online you can see that, and as we bring our speakers up, we'll put that up, and you can see further things about Dr. Williams. But thank you so much for being here.
Okay. I'll give a little description about the continuing education credits. As Mercy Health St. Rita's Medical Center is so kindly been able to get this together for us so we can have a continuing education for nurses as well as for physicians and pharmacy. So thank you, Mercy Health. Online folks, I noticed in the chat that you had mentioned about the microphone. Is that better? Because it was on the owl before, and I just wanted to check and see if you can hear me better. Please use my card to hear you. This is different because I don't think they can unmic. Oh, they can hear me much better. Thanks, Jill. Still hard to hear. Okay, well, we'll be back and forth a little bit. So we'll speak up as loud as we can around this area. The slides, everything is going to be recorded so we can provide this to you. I've sent an email out to, I think, everyone on how to obtain your credits. So follow those prompts that'll be open and available for the next 2 weeks. I will tell you a little something about this owl, which is a very awesome tool that gives a 360 view. However, if you start crunching on a Cheez-It or have a side conversation, it will side pan you onto the Zoom. So to avoid any embarrassment on your end, I just wanted to let you know now that even pen tapping might be like, and it really is an owl. It hooted at me and everything. So I will continue it and I know I told Christy's helping with the slide. Yeah, I know, 5 minutes. Okay, I got it. So I will control your slides if you,
Okay,
and this way
great.
you don't have to think about
All right.
it. All right.
Well, we're going to talk about tuberculosis infection this evening, otherwise known as latent tuberculosis and inactive tuberculosis. I don't really have any disclosures. Some of my learning objectives, I wanted to talk about the epidemiology of tuberculosis and to understand the new kind of classification, or just understand that I'm going to be using TB infection versus TB disease. I think it just makes more sense that way. But when I say TB infection, I'm also talking about inactive, latent, and sometimes I'll use them synonymously, even though I will try not to. And then I wanted to talk a little bit about the screening test. I think Dr. Schlaubecker is also going to be talking about that, so maybe I won't hit it too hard for you. And then I wanted you to understand the evaluation of TB infection versus TB disease, and discuss some treatment options and how should we follow these patients after we've treated them.
Oh, two.
And so just by the numbers, 1.3 million people died from tuberculosis in 2022. And so it's the second leading cause of infectious disease killer after COVID-19. And there were 10.6 million people who had TB disease worldwide, including 5.8 million men, 3.5 million women, and 1.3 million children. And so it's present in all countries and all age groups. 2.7 to 5% of the US population have TB infection, AKA an active or latent TB. And so greater than 80% of those TB infection of the TB disease, the TB cases result from TB infection. So 80% of the TB disease in the US result from TB infection. And so 5 to 10%, oh, I said that wrong, sorry. 5 to 10% will go on to develop TB disease from TB infection. So in the US, we spend $13 billion annually for TB prevention, diagnosis, treatment, and care. And then one of the goals set by the United Nations is to end the epidemic by 2030, which we still have a lot of work to go. Okay. And so how is TB spread? Well, it's spread through the air from one person to another. And so, those TB germs are in the air from a person who has TB disease, when they're talking or coughing or singing. And we know that from, particularly from COVID. And then somebody else comes along and breathes in those germs. And so it can settle into the lungs and it can begin to grow there. And from there, it can move through the blood and the lymphatics to other parts of the body as well. And so who is at risk for getting TB infection? Well, anybody can get it, but some people have a higher risk of this infection. And that's, like healthcare workers who are exposed to patients with tuberculosis disease. It's people who were born in or frequently travel to countries where TB is endemic. And it's people who live in places who are high risk for TB transmission, like homeless shelters, jails, nursing homes, even some of our mycobacterium lab workers. And so I just wanted to kind of reiterate, even though I confused you already, about TB infection versus TB disease. So, like here, this would be TB infection. So the patient doesn't have any symptoms, they've been exposed, but so far their body is keeping the disease kind of walled off, the infection walled off. And then sometimes we find these subclinical tuberculosis disease cases, when we're doing like a contact investigation. And this is kind of like the early point of that. So it's kind of before they necessarily have symptoms. Things like the chest x-ray, we might not see anything on there yet. And then kind of, as time progresses, they go on to develop active TB or TB disease. And so, in subclinical and active, it is kind of where they're infectious. And then, even after we treat somebody for TB disease, they can still have evidence of having had tuberculosis, like on their chest x-ray, for example. And so this is really, it looks complicated, but I think it's helpful when we're thinking about the pathogenesis. And so, like somebody's exposed and they get primary infection. And so, it's always described as like this bone complex on their chest x-ray with kind of like the lymph nodes that are more, kind of bigger. And then, like 90 to 95% of those cases are contained and they go on to develop TB infection. And so at this point, their TB testing, blood-wise, would be positive. We'll talk about that a little bit more in a minute. But 1.5% of the cases, go on to, in this primary tuberculosis process, it can spread. And so sometimes at this point, it will look like a pneumonia or a consolidation. And, a lot of times their testing will be positive for tuberculosis here as far as like cultures are concerned, from the lungs. And then another 1.5% of cases, might spread through the blood or lymphatic tissue to other places like the brain, the bones, the adrenals. And then, a lot of, some of our TB from the latent or the TB infection can go on to reactivate. And this would be kind of more of like a secondary tuberculosis, which is much of what we kind of see on a regular basis. And it can reactivate, in the lungs, or it can reactivate to these extrapulmonary sites. So I hope I didn't confuse you too much. And so what are the symptoms of tuberculosis? Well, it's things like cough, coughing up blood, fever, chills, drenching night sweats, weight loss, loss of appetite, fatigue. And then if you have, extrapulmonary tuberculosis or tuberculosis somewhere else, you have it in your kidney, you might have blood in your urine. Or if you have meningitis, you might have a headache or confusion. And so we're differentiating between the TB infection versus TB disease. So TB infection, no symptoms. They would have either the positive blood test or the positive skin test. And their chest x-ray should be normal. And then, typically their respiratory cultures, those would be negative. And you can't spread, TB infection to somebody else. And we should consider these patients for treatment because it reduces the likelihood of them developing TB disease. And so TB disease, we talked about the symptoms, and, they would usually have a positive TB blood test or the skin test. And their chest x-ray, if it's pulmonary, we would expect an abnormal chest x-ray. And then their cultures, their acid-fast cultures that we get, those are typically positive, unless it's extrapulmonary, may not be positive there. And then, they are infectious and they do need treatment for their TB disease. And again, this is kind of that spectrum where this would be TB infection. If we were to do their cultures, they'd be negative. Their chest x-ray would be normal. And we would identify them as having TB infection and would, offer them treatment. And then there's this subclinical disease, which is kind of on its progression to active TB disease. And like I said, these are normally picked up on our contact investigations. And they may not quite have positive cultures yet. They might have minimal abnormalities on their chest x-rays. We would still treat them once we have identified that that's what they have. And then, for TB disease, what you think about, they would have the extensive cavitary lesions. These are often the people who present to the emergency room or to their primary care doctor, and we would treat them as well. And so, the biggest thing is you want to exclude TB disease when you're evaluating somebody for TB infection. And so, typically what we'll do is we'll get referred somebody who has a positive IGRA or the skin test. And really they don't have any symptoms. We would get a chest x-ray. And if it's normal, then we would go ahead and start them on treatment for TB infection. If it's, if they are symptomatic or if their chest x-ray is abnormal, then what we do is we collect the sputum cultures. And so, if they're not coughing anything up, sometimes we can do some things to help them get those sputum cultures for us. And then if they're positive, they would go on for treatment for their tuberculosis. And so we kind of went through the pathway for the latent or the TB infection. I didn't talk about this yet, so don't read too much into that. And then for the active treatment pathway, we talked about the active case finding versus a passive case finding. Active would be like part of our contact investigation. And kind of what gets gray here are the people who, their chest x-ray is abnormal, but you get cultures and you don't, maybe their cultures don't show up. So then you kind of have to make a clinical determination about whether or not you treat those people for active tuberculosis or not. And sometimes in the treating for the active tuberculosis, that would also treat their TB infection. And so we do the skin test, and the skin test is where they inject the tuberculin protein into the arm, and then the patient has to come back, and you have to measure the induration in the arm. And so it requires 2 patient encounters, and sometimes we lose patients kind of because of that. And then it also can cross-react with the BCG vaccine, which is what a lot of countries use to decrease the likelihood of TB infection and decrease the likelihood of severe, tuberculosis disease. And so, we still do that, but I think more and more we're going more towards the quantiferon. And there's also the T-spot. So the quantiferon, this is an ELISA test, and you actually get these 4 tubes of blood from the patient. It's more expensive, so that's definitely can be an issue. And there's some interpretation to this. Like it's measuring the TB1 and 2 antigens versus the kind of the background the background interferon gamma that the patient has versus the mitogen, which is the control. And so, but it doesn't cross-react the BCG, so you feel better about that. And then the T-spot is just kind of a different way to do that. Instead of the 4 tubes of blood, they do the 1 tube, and they kind of do it backwards versus how they do the quantiferon. And so if the blood test is positive, then that tells you that they have, tuberculosis infection. If it's negative, you can still have TB disease and have a negative skin test, particularly if it's that primary process that I was talking about. And then if a patient has a high risk for developing TB disease once infected. So if they are immunocompromised, that might affect your quantiferon test because of that background interferon. So yeah, like an indeterminate, that can be the case for that. So, and sometimes for the T-spot, if it's borderline, if you repeat the blood test using a different quantiferon instead, that might, is sometimes helpful. So how do we interpret the skin test? Well, it kind of depends on, you know, who you are. So if your induration is greater than 15 millimeters and you don't have any risk factors for TB, that's a positive for everybody. If it's greater than 10 millimeters, then you would count that as a TB infection if you were, you know, born in a country where TB is endemic. If you're somebody who abuses drugs, if you work in the lab, if you know, are working in a nursing home, a homeless shelter, healthcare, correctional facility. If you have a low body weight, if you're a child younger than 5 years of age, and if you've been exposed to adults in the high risk categories. And then for greater than 5, it's people who have HIV, if they've had a recent contact with somebody with tuberculosis, if they've had an organ transplant. So, you know, you wouldn't expect them to mount as big a response. And so I think I've already talked about the advantages, so we'll skip this slide. And so who goes on to develop TB disease? So these are people who already have TB infection. So we're worried about them developing TB disease. So it would be somebody who's recently been infected. So, you know, within the past 2 years, you're at higher risk. If you have HIV, if you're a substance user, if you need to be on medications for rheumatoid arthritis or Crohn's disease, like the TNF-alpha inhibitors, organ transplants, severe kidney disease, diabetes is really a big one. If you need to be on steroids repeated, you know, for a long period of time, silicosis and low body weight, and children too. And then in 2022, diabetes was the most common reported risk factor. So I think that's important to remember that 1 in 4 people with TB disease also has diabetes. So we really need to be thinking about that in our patients. And so I like to show this to my patients because it helps kind of like plug it in for me. And so I just entered in my own data. This is the McGillis risk calculator. And I just entered in my own information here. And it tells me, like, if I had a positive IGRA based on where I was born and my age and all that, the likelihood that it's a true positive test is 98%. And my annual risk of developing TB disease is 0.1%. But my cumulative risk up to the age of 80 is 3.53%. Now, if I have diabetes in my family history. So if I were to develop diabetes, then like this number, my risk up to age 80 goes to like 13%. So, and this is not static. It changes, if you develop any of these risk factors, your risk can go up, and it's much easier to tolerate the latent TB treatment when you're younger and otherwise healthy, particularly than it is to go on to, tolerate the treatment for tuberculosis. And so these are our treatment options for TB infection. So we do a lot of rifampin. And so usually that's like 2 pills once a day for 4 months. And that would be treatment for TB infection. And that's pretty well tolerated. You do have to be careful about drug interactions. Alternatively, isoniazid and rifampin, which I don't think we do a whole lot of that here. That's like 4 pills once a day for 3 months. Also, there's isoniazid and rifapentine, which that ends up being like 10 pills once a week for 12 weeks. So a lot of times we can do like some video DOT with that too, just because it helps increase compliance. And that would be like kind of for a standard person size. Or alternatively, you could do isoniazid for 6 or 9 months. And so, like treatment is optional, but certain risk factors would really push me more to get patients treated, like things like HIV, recent exposure, or if they're going to be immunosuppressed. And then, like I said, careful with the drug-to-drug interactions, because rifamycins are cytochrome P450 inducers, which means that it reduces the bioavailability of other drugs that use that enzyme. So it'll make things like birth control ineffective. And then, there's lots of drug-drug interactions for HIV patients on their medicines. I always warn patients that the rifamycins can turn the urine orange and can stain the contact lenses. And then for INH, you would need vitamin B6 for neuropathy. And then, you have to explain to patients that they really need to take this in a time-sensitive way, meaning, it's not going to be preventative if you don't take, the course of the medications. And then people favor the shorter regimens. Got to be careful about things like alcohol and Tylenol consumption, because these medications are filtered through the liver. And we always counsel patients on signs and symptoms of hepatitis, like yellowing of the skin and yellowing of the eyes. Usually we'll get like a baseline hepatic function test on patients, sometimes a CBC. Okay. And then, just some of our barriers that we have as far as like long waiting times for appointment. I think we're actually pretty good here at Hamilton County. But it costs, and their funding is always being cut. So, just poor access to healthcare for a lot of our patients. So that is definitely can be difficult. And then, there's a lot of stigma associated with TB. I had a lady who, she wouldn't tell me that she had TB infection or TB disease in the past, because she was so afraid that her husband was going to find out. So she didn't want me to put that in the medical record because of the stigma that was associated with that. She was afraid her husband would read it. So that still exists. And then, TB infection treatment, it lowers the risk of reactivation, but it doesn't protect against reinfection, and it doesn't account for multi-drug resistant TB. And these are just pearls. Chest X-ray should be performed if you were to develop symptoms. You should continue to do a yearly symptom review with your primary care physician. Not all countries treat for TB infection. Some use the BCG vaccine instead. And then, explain to patients that their TB screening test will likely remain positive for life. So if you have a positive skin test, you probably shouldn't have that repeated, or a positive quantiferon, I wouldn't repeat that. And then in cases where multi-drug resistant tuberculosis, sometimes we'll use like levofloxacin or moxifloxacin for that. I think that's it. Yeah. Yeah, sure.
Is there testing for multi-drug resistant TB?
Do you mean like? Yes. Yeah, absolutely. Yeah, I mean, a lot of times they will, there's some molecular tests that they can do that'll tell us a little bit about resistance. And then sometimes if those are flagged, then we'll ask them, can you go ahead and give us the secondary panel of the multi-drug resistant?
ODH lab will provide the first line drug susceptibility with a positive MTBC confirmed through culture. So, all right. Cool. Thank you.
Okay. Thank you.
Our next speaker is about pediatrics, and it's my pleasure to introduce Dr. Emily Schaudecker, who is the division chief for infectious disease.
No, I'm just the medical director. Yeah.
All right, you're the chief for me. Anyway, at Cincinnati Children's. Well, in fact, she's actually on service this week.
I am,
This
yeah.
month. Yeah,
Samir
thank
Shaw
you.
had to take his kid to college, so I'm covering a couple days. So, yeah, thank you guys for having me. I met lots of you before, and sometimes in the virtual setting. So it's good to see the clinic, and certainly to be here in person. As mentioned, I'm in the Division of Infectious Diseases over at Children's, and we have been very thankful for the expertise of many people in this room over the years. A lot of my TB learning came from my time in training that I spent several rotations over the years in Kenya and Cameroon, and took care of lots of kids with TB, but fortunately, we don't see as many cases of active TB here in Cincinnati, but on the rise for sure. So I'm going to jump right in. I think a lot of what I have to talk about meshes very well with Dr. Williams' discussion. And I also think it's very funny because I do think that I've tried so hard over the years to not say latent TB. I've tried to switch to TB infection to explain, because I think latent TB is confusing, but it's not dying. It's not going away. And I have succumbed to the pressure, and I usually call it latent TB infection, even though I understand why TB infection and TB disease are a great way to call it. So I am today going to talk a little bit specifically about the epidemiology in children, and then more specifically about diagnostics and treatment in children. And of course, I'm specifically talking about latent and or TB infection, and that is the majority of the cases we see at Cincinnati Children's. So as you guys just heard, 2022 is the latest data we have. We both use that. And in the United States, the incidence rate was 2.5 cases per 100,000. And if you look at the graph, we totally dropped off the map during COVID because we weren't really checking. We were all a little busy, and we weren't really paying attention maybe as much as we should have. And then of course, it's been steadily rising back again since that time. In the US, there were 317 cases of TB disease among children 14 years or younger, which doesn't sound like that much, I know, in the grand scheme of things, but that usually means there are many, many more cases of kids with TB infection and lots of adults with infection, because that's usually what the kids, they usually get it from their parents. So overall, about 4% of US TB cases occurred among children less than 15 years of age. So I know it doesn't sound that important, but I am going to argue that, the children are a big part of your future patients. And so we should also be making sure they don't get active TB. All right, so this is the graph that is again from that same CDC data that we shared. And it's showing that the little purple along the bottom is 0 to 4 years, and then 5 to 14 and the darker purple. But as you see, when you're getting up into those teenage years, and this is tricky because these are like half my patients and half your patients. So, and you're getting into those teen years, you're starting to see a bigger chunk of the light purple, and therefore more TB cases. And again, this is another way of looking at it. The top purple is 0 to 4. And so it is somewhat evenly divided in the age group. In children, you can see, and again, it's most likely because they get it from their parents. And so you can see as they get to be older in their teen years, we're seeing more males. And I definitely would agree that that's true in our practice. And I think a lot of it is because the kids that come from outside the United States are often young teenage males or young adult males. So again, as mentioned, it's a persistent pathogen that has airborne transmission. Following that new infection, 5 to 7% of adults will have active TB in 2 years, but they're higher rates in children. So that's again why we are concerned about kids. And we really have a policy at Cincinnati Children's that if you have any kind of TB infection, i.e. latent TB infection, no symptoms at all, we strongly believe the children should be treated. And we don't really give it as an option, even though we do have parents come to us and say, we're from India, we wouldn't treat this in India. And we will usually work hard to make the case that they should treat their children. And then of course, reactivation TB has the highest chance of occurring in the first 2 years. So we talked a little bit about this, but in my bright green here, it's those infants and those post-pubertal adolescents that have increased risk of progression from TBI to TB disease. And of course, we already talked about other reasons. We actually see a decent number of kids at Cincinnati Children's with a lot of these other medical conditions and immunosuppression who get the test before they're started on therapy for their Crohn's disease or their some sort of rheumatologic disease, and they often are coming to us for treatment. But I would definitely say that a lot of the kids we've been seeing lately are kids who have come from outside the United States and are either infected or exposed to their parents or possibly from their home country. So I did briefly talk about this because I know we all mentioned this and Dr. Williams went into this a lot, but I do think it's important, and it often is very confusing to families. And actually, I find it's even very confusing to a lot of non-infectious disease doctors at the hospital. I think it comes automatically for a lot of us, but I find that a lot of people are a little confused on what it means to have TB infection versus disease. So something that's good to know. So really, this is the part where I think it gets a little trickier in pediatrics and is a little different than adult patients. So when I was little, and so I'm in my mid to late 40s, we all got the little time tests to check. Everybody got checked for TB. And then over the years, we have realized, and actually, even when I started out at Cincinnati Children's, every single person in the hospital got a PPD every year. And we've realized over the years, this is not necessarily an effective strategy. And we were ending up treating a lot of people who do not have any risk factors for TB infection. And of course, it really is likely to lead to unnecessary treatment. It's hard to decide whether or not it's a false positive. And we assume that they're all false or not false, that they're all true positives. So this is why we try to selectively check for TB. And of course, we are thankful for everyone over here in Hamilton County Public Health that do the contact tracing and check kids and make sure that we're not missing the ones who are actually at high risk. But of course, it's not always perfect. We don't always find kids that maybe we didn't know they were homeless. We didn't know their parents were in jail, and we maybe should ask. So we do try to ask as much as we can in the hospital and make sure we're not missing it. So again, universal testing with TST test or IGRA test, especially ones in schools or childcare centers, they are not encouraged. So we do not recommend testing large swaths of the pediatric population because it's either very low yield, so very expensive to test all those people for a very low yield, or you potentially have false positives leading to inefficient use of healthcare resources. So that, I think, I have definitely seen the swing in that perspective over the years. And I do think it is important to recognize that, we don't have a good way to prove that a test is a false positive. So we should be judicious in who we test. So this is what's recommended in the Red Book. For those of you who don't know the Red Book in pediatrics, it's our American Academy of Pediatrics Bible of infectious diseases that we use for a lot of things. So there are a list of questionnaires that the Red Book recommends, and basically kind of the same process that's used in adults. Do you have a family member or contact with TB? Do you have a family member with a positive TST? And was the child born in a high-risk country? Basically any country other than United States, Canada, Australia, New Zealand, and the Western and North European countries. And have you traveled to those high-risk countries? And this is something that we, even today on service, I have a couple kids who are presenting with respiratory disease of unknown etiology, and one has some weight loss and things like that. And so, this is the first thing that I talk about when we get in the room and try to figure out what the risk factors are. So we talked a little bit about the TST and the quantiferon. It, of course, it is an art, and I'm sure you guys are really good at it. Our ID nurse used to have to do it for all the employees, our PEDS ID nurse, and she was so good at it. She did a great job. And we would often get referrals from outside pediatricians who had not done it exactly right. You know, they got too deep, or they, you know, they were calling induration. So I remember back when I was training 20 years ago, we used to bring every kid in who had a positive PPD, and we would do it again. We would do it again in our ID clinic. This was before we had quantiferon. And then it was tricky because we only have clinic on Monday, Wednesday, Thursday. So we were trying to fit them in so that we could check it again 48 to 72 hours later. And this was kind of our standard of care at the time, because we felt like, okay, our only choice, if this is positive, is to give you 9 months of isoniazid. So we want to make sure we get it right. So now we are leaning much more towards getting quantiferon gold. It has recently been recommended, as most of you know. The Red Book now recommends it at any age group, which is a big change. There was a long period there where we didn't really have the research or the evidence to give it or to test in that way in younger kids. It is now recommended in any age group. However, I give a caveat to this because I kind of polled my colleagues. Many of you know Dr. Mary Stat. She's a peds ID doctor, and she runs the International Adoption Center and the Travel Clinic. And I would say she has told me she's seen a lot of kids who got BCG as a kid, and then as they get older, their quantiferon is no longer reactive. And so she said, we don't really have the data yet to suggest how long it is going to be reactive. So this is part of our ongoing conversation at Cincinnati Children's. She likes to get 2 kinds of tests. I think the rest of us really shy away from getting 2 tests because you're often in a predicament when you get 2 kinds of tests. So I'm going to jump into the next one and we'll go into that a little bit more. So of course, tuberculin reactivity appears 2 to 10 weeks after initial infection. So when you guys send us kids that are under 5 who've been exposed to TB in their house, we put them on window prophylaxis and we recheck a TST again or a quantiferon about 10 to 12 weeks after they come to see us. And of course, it likely is a little bit shorter than that. And BCG immunization can produce a positive TST result. So this is like a big can of worms in the land of pediatrics, as you guys know. So BCG is, I've been to a lot of talks now about, actually, I used to get really angry with BCG because I'm like, why do we give everyone BCG? And all it does is prevent TB meningitis in babies, and it really doesn't do anything else. And now it causes all this confusion and we can't diagnose anyone. But then now there's all this really, new novel stuff that it prevents sepsis in babies maybe, and it does something cool to the immune system. So I'm having a bit more of an open respect for BCG. We're learning, we'll see how it goes. But so far, we still see a lot of kids with BCG vaccine. And so this is a lot of information on one page, but this is sort of the diatribe from the Red Book on what to do with a kid who's had BCG and has a positive TST. And there's a lot of, humming and hawing involved with this. It's a lot of like, well, it probably is positive for a little bit, and then I'll get you in a second. But in general, you should ignore the fact that they've had a BCG. That's kind of the bottom line. So there's a lot of like, it matters what age they were and when they're treated and have they been exposed. But at the end of the day, we try to ignore it for the most part. And yes, question. Oh yeah, thank you. Oh yeah, I thought you were asking me a question. So anyway, that is something, actually it's on our PEDS ID boards every time. I don't know if it ends up on the adult ID boards because they also have adults who have BCG and therefore sometimes get TSTs. The other thing that comes into play is, of course, if you're 5 months old and you just had a BCG, we would expect it most likely to be larger than maybe when you're 50. So that is sort of the take home of that. So again, this is the same rules for in the Red Book on 5, 10, 15. So I won't go through that again, but we interpret it differently based on your risk factors. And of course, as I said before, if you are screening a TST, you are deciding that you will treat if it's positive. And I think that's an important thing to point out. If you put a TST on a child, there's not a good way to argue out of it at the end and say, well, it's probably a false positive, because there's really no good way to determine whether or not it's false positive. So of course, we're relying a lot more on IGRA testing now. The quantiferon gold and the T-spot, we have a lot. Mary Stott loves the T-spot, but for the most part, quantiferon gold is a lot easier to get, a lot more readily available. And the big thing that we talked about, of course, is that it hopefully avoids some of the bias associated with BCG. It basically measures your ex vivo interferon gamma production. So I think that the bottom line right now is we generally recommend pick one and stick with it. And if it's easier to get a quantiferon because you only want to see them once, then get the quantiferon if they've had the BCG. Or if you decide to get the TST, go with it and treat it and commit. We have much better treatment options now. You don't have to give 9 months of isoniazid. So we're like, pick a test and stick with it, and don't like go back and forth and try to like, well, we'll get another one to see if this one's negative, and then we'll get another one to see if that one's positive. And that usually ends a rabbit hole. So this is my last slide. This is exactly what you just heard, except to say that we actually have one more after this. We have tried to switch as much as possible to isoniazid and rifapentine because it is the first line recommended because it's easiest. That, of course, you obligate yourself to do video DOT with it, which has made it sometimes very challenging for some families who do not have easy access to a phone or, so sometimes we'll collaborate with a school nurse and they'll give it to them. And then 4 months of rifampin is our next choice, but we have in our teenage girls, I get very nervous about putting them on rifampin, especially if they're sexually active, and teenagers cannot always be trusted. So they'll tell me like, I've never had sex in my life. And then they come in pregnant. And then the same thing with alcohol and isoniazid. I usually give a very scary chat to my teenagers about how, you could really, you could go into liver failure. And this is, if I will tell them, if you're going to go on spring break and drink and have sex and not take your medicine or take your medicine, then I would rather wait for a better time to start therapy for you, because I really, I don't want it to cause more harm than good. So we did a little study. You guys know about 3HP. That was a big deal. We did a little study of our experience at Children's a few years ago. I had a medical student working with me, and it was a big deal. We actually had pretty poor, none of the other studies, Jeff Stark is sort of our PEDS ID guru down in Texas. Nobody else had these low rates sorry, I was not showing you the right one. We had a lot of our kids not complete treatment. They either threw up, there was some allergic reactions. A lot of these teenage boys like really don't tolerate the big chunk of pills, and we make them take the first one in the clinic, and we've had many of them vomit them all right back up right afterwards. So I know you guys maybe have the same experience, but that's not what the literature says. They all say it's super easy and you all should be on it. So we're, the other big thing that we have at work is one of our fellows is very interested in social determinants of health and adverse childhood experiences. And she just wrote an abstract in the first part of her manuscript analyzing our pediatric TB population and how we actually have a lot of problems with completing therapy, getting to clinic based on your social determinants of health. So next time we'll chat about that, because she just sent me the draft of the abstract yesterday, so I couldn't quite put it into the talk yet. So anyway, glad to have a little time with you guys, and I would be happy to take questions, but we can do it panel-wise if that's better. Yeah.
Right, so we'll invite our panelists to come back up.
We'll start the panel and take your moderating. You're also invited Dr. Madulika, I don't know, but Mamidi, who has an outstanding, really interesting background working with immigrant families and refugee and immigrant families, and related to the infection. We also are inviting up Dr. Woman, who, by the way, is the Associate Professor of Medicine, co-lead researching it, and also Dr. Lisa Hagman for our panel discussion.
Am I going to?
Like to ask questions of the panel. So Dr. Potter here actually talked about not screening with the TB, except that that's exactly what the U.S. Immigration Services does.
Right, I know.
So,
Yeah.
what are your thoughts on that?
Yeah, I know. It's, well, by definition, a lot of the places they're coming from, they do have a much higher risk of TB. So, I think it's very tricky. You know, we all know that from our medical training. The screening test is a fine balance. Any screening test, you know, we want to get all of the people with the disease, but we also don't want to get all the extra people that aren't at risk for the disease. So I understand from an immigration standpoint, it is a pretty, but I think the tricky part for me is it's like every country does it differently. The data that we get is, you know, it's not like we're getting a quantiferon in every single person that comes in. So I do think the way it stands is not ideal, but I do tend to think that we underestimate how likely it is. Like there's still a decent risk.
I was just ask Dr. Woman, what is sort of your go-to in terms of latent TB infection and treatment as kind of outlined here? Because that's always confusing to us primary care. It's like you infect these guys, you have 8 things, like 8 answers for one question. And we're like,
And
what do you do?
everyone in my division is like a little bit different. I know, you know, we're all like, well, I kind of like this one. And I know it's not great.
Yeah.
So my go-to would be rifampin. Obviously, the rifamycins have a lot of drug interactions. Look up every single medication they are on because some of them aren't obvious. And the rifamycins will reduce the effectiveness of all forms of hormonal contraception. Period. So you really have to talk about barrier strategies when you're putting someone on rifampin. In Butler County, we have had a surprising amount of problems getting people started on INH and rifapentine because the pharmacy doesn't carry the rifapentine. And so you write these 2 prescriptions at the same time, and they go home with 72 tablets of INH, but they don't fill the rifapentine. And the patient doesn't quite know what to do. And I've even had the experience of a pharmacy giving a patient rifabutin, an alternative rifamycin, instead of rifapentine. Well, now what do you do other than, tell the patient, don't take that? And we'll try to get them to, do the right thing. And then you call and yell at the pharmacy and they're like, well, I don't know who's on that weekend. So we've had a lot of logistical issues. Rifapentine is expensive. It's not readily available. A lot of the Butler County folks don't have insurance. And so GoodRx coupons are go-to. And so rifampin for 4 months, that's my go-to right now.
Yeah, so here, thankfully, we have access to the
You have the pharmacy.
isoniazid and rifapentine from our local pharmacy here at Hamilton County. Nikki, where's Nikki? Oh, yeah, she's our pharmacist. And the patients who come referred to us for TB infection treatment will get access to 3HP, and the program will cover the cost. And we have the capacity to do the video DLT. So we have had good experience with doing 3HP. There have been a few situations where, because this is an unusual occurrence, but it does happen. I've had some patients who had this systemic kind of flu-like illness reaction and ended up in the emergency department, and the pathogenesis of that kind of flu-like illness is not well understood, but apparently it's related to the fact that it's an intermittent dosing of the rifamycin and the INH. But other than that, we have been successful on putting 3HP, the weekly regimen, as kind of one of our preferred regimens, and rifampin also. I know Dr. Cutillo likes
I
rifampin
do
over
for my
3HP.
usually. I usually talk about the options, and once a week, a lot of pill burden for that one day. Maybe some more side effects versus rifampin every day, or so I often have patients choose rifampin because they prefer daily, and it's hard to remember a weekly dose. But you know, I've had patients with both. But I think I trained with you, Dr.
I also find that for a lot of patients who have either limited literacy or limited health literacy, kind of trying to drive home the point of this is a very serious progression. Like if there is a progression to illness, there is a very serious consequences. A lot of patients will respond better to a daily dosing regimen as opposed to a once weekly dosing regimen in that particular population. Because, oh, I have to take a daily medication for the next 4 months, drives home the point of how serious illness can be versus, I know for some patients, when I was initially trying to do intermittent dosing, they're like, well, I only have to take it once a week. Like, I'm not sure how serious this is. So, especially from a PCP perspective, having that perspective has been really helpful and interesting. And for that reason, I also do for our, even though I do have a lot of patients who are of reproductive age and are sexually active. So definitely a lot of education and conversation around that.
I have a question, Elizabeth, and maybe I just missed it in this slide. You did mention infants, but on the treatment, it looked all like. So what are
Yeah, I was about to mention that. That's a big challenge. So, you know, the access to medicines has been a big problem at Cincinnati Children's because they don't even keep the pills in stock regularly. And then all the children, so actually, I mean, really, honestly, like 10 and below, we usually have to get it. They will compound it and make liquid for us at Cincinnati Children's. And so what we've been trying to do is predict what regimen we're going to put them on, and then we will tell the pharmacy in advance, we have this family coming in and we will likely need isoniazid liquid prepared. And they often don't have insurance coverage. So we have to get them down to the pharmacy and then down to financial services and plus or minus to the radiology for the chest x-ray. So we have found that, and then we get there, and even when we tell them in advance that, well, we only have a week's, so they're gonna have to come back again in a week. And I'm like, wait, they barely got here in the first place. And so, yeah, that has been, I think, the biggest struggle for us, having the medicines available for them. And especially in some of these families where we have, you know, mom or dad has active TB, and one of the kids has active TB, and 2 of them are in window prophylaxis, and one of them is getting tested. And so it's those families have become very overwhelmed, and there's just not enough medicine to get them all the medicine. So yeah, I think this is the big problem with tuberculosis in general, is it's a neglected disease. And so we're using these medicines that we've been using. I mean, of course, it was a really big deal when we switched to 3HP and had rifampin as an option. However, it's still, you know, it is not a moneymaker for all these pharmacies to have these medicines in stock. And so, you know, I get all bothered by it, but it is something that we are working on at Children's and trying to explain, you know, the public health importance of treating these children so that they don't get it later in life. But yeah, no, it's definitely a challenge.
See enough children here. Not anymore. Not used to have. Yeah.
2021.
At the time when I started, I was. We have done that here when we have patients.
We had
That's
one,
great.
one young man here, he wouldn't accept the liquid. And so the nurse was taking pixie sticks, the citric acid and sugar. She'd dump out the sugar, grind up the pears and bond and the inditol, mix it all up, put it back in there, and for him, it was the biggest treat.
Actually, the recent, the baby that you guys were taking care of the mom and she was at Good Sam and then we were taking care of the baby.
Right.
The baby, the dad ended up making some, he like crushed it and they also couldn't get the baby to take the liquid and it was, so they used an interesting crushed something to get the baby because the baby was only a month old, yeah. With active TB, yeah.
We tried putting in formula too.
No, I know, there were, you guys worked hard, I know.
Two of the meds, Christine knows better as a patient, but two of the meds caused, he liked it, and then there was one really foul medication. Because he was on the PCA and the MCA, and he just immediately was like, absolutely none, but the Revamp sucks. He's now a year old.
I know, he's a big guy now, I know, that was, yeah, that was stressful. But yeah, they, it's definitely something, I remember talking about that when I was a resident 20 years ago. There were no new vaccines for TB and no new drugs for TB, and I'm like, man, things have not changed a lot in 20 to 25 years. We've had some improvements, but not totally better. Yes.
Are there any advancements in rapid TB testing?
I only know, I mean, obviously quantiferons have revolutionized the way that we test for TB, like all the IGRA tests. But I don't know very much about point of care testing, if there are any new technologies. I don't know if any of you know about, especially in low resource settings, if they have any better options.
Nothing that is on yet. There have been presentations of point of care testing that are still being validated. So in the future, we will have some newer tools, both for screening of TB, tuberculosis infection, and active tuberculosis. But
So talk about, yeah, that's kind of the international standard and locally. Actually, not that much. Well, 60,000. And let's do some gene, you know,
about the, you mean like the expert, expert?
Yes, yeah.
Yeah, most, I mean, this is a platform that is now being used not only in the US, but in low income settings as well, that does molecular testing for active tuberculosis, can detect not only presence of the bacteria in the sputum, but also gives you information on resistance, particularly to rifampin, although there are newer generations of the test that are checking for resistance to other drugs as well. That's thankfully that is widely available these days worldwide.
And I think one of the frustrations, at least for public health, is that technologists do bronchoalveolar lavages and you get mycobacterium and then you don't know what to do with it. And it shows.
We send all of our, we have an excellent microbiology lab at Children's, and obviously they identify the mycobacterium, but we send all of ours out to National Jewish. They do all of our testing. So that takes a little while sometimes, yeah.
I'm looking at the questions from Zoom, and one of the questions from Belinda says, any link between COVID infection or vaccines and positive quantiferon labs? I have had a number of patients with no symptoms, positive quantiferon, and a couple requests to be retested. The retest came back negative.
when they were positive with COVID. Is that what they were saying?
Belinda, were they positive with COVID? That's the follow-up.
There's some bizarreness. And
Yeah.
these are potential false positives aren't here on post-COVID.
I have not heard that specifically.
So, you see, during the COVID, we did have some fellows do a study. At the time before giving someone IL-6, we were checking quantiferons. And the levels of interferon in the control tube actually correlated. The higher the levels, the worse they did. And so it could be really confusing. You may need to look at all 4 numbers to make sure that it's interpretable.
Right.
Because it might be pretty
Your
scary.
control might not be
The control might be
acceptable. Yeah, at that time.
And if you look at it, you'll say, it makes sense. But if you just say positive or negative, you might be misled.
Yeah, that would make sense.
So there's a tremendous acute inflammatory. Is there any recommendation to wait quantiferon at this time? Or?
I've not heard of any suggestion to do that. And it is interesting because COVID is so ubiquitous now. I think it would be very challenging to do that, you know?
I mean, and you're still looking at like the TB antigens for quantiferon too. And I think, you know, like a lot of our treatment for COVID was immune suppression. And so, I mean, you know, maybe energy was playing a role in why the quantiferon became negative, just kind of based on the steroids that those patients were receiving. And a lot of them received like tocilizumab and, you know, some of those immune suppressants too.
No, if I would test again, would you all?
No.
I don't. Do a second test. Yeah.
We strongly discourage that, you know, it doesn't really, you're not going to ignore a positive.
Right.
If you get a second negative. I mean, you can't just keep testing until you get the answer you want. I felt like people did that with COVID. Like, I'll just keep testing till I find the right answer that I would prefer. No, that's not good.
On that note, if you have someone who has been successfully and per the guidelines treated for TB infection, you're doing your symptom screening annually, you know you don't want to retest them at any point. In the world of many respiratory viruses going around, which are going to also have like normal x-rays, like at what point would you get another chest x-ray knowing that this person, you can't rely on a quantum? Which of those symptoms of the classic symptoms would prompt you to look a little bit further?
I think it would be like a persistent cough, you know, a cough longer than weeks. And just, you know, and then, you know, maybe some other symptom in addition to that. Or, you know, like looking at their risk factors, you know, if they're underweight or, you know, if they have HIV or, you know, something else that would really kind of push your positive prediction.
And I was going to say exposures, you know, if they have a new exposure, obviously a direct exposure, or, you know, they've been in an endemic country for a while or something like that, we'd probably reevaluate.
For some of our immigrant patients, and they have recently returned to country of origin. Like often we do, not everybody comes in for a travel screener, travel vaccine. So sometimes I'll find that, oh yeah, I did go back to Senegal for 3 months and I just came back a couple months ago. Can be a very helpful option.
And to piggyback off of your question, I'm new to the world of correctional medicine. I just started at the Hamilton County Jail back in February, and we had a circumstance where a young man had a fear of exposure. There was no documented actual exposure, but he did have a positive TST. Chest X-ray was negative. At what point do you decide, no risk factors, no comorbidities, no anything like that? At what point do you decide treat, or it could be an allergy to the tuberculosis serum?
I would never call it I would treat it, you know, unless you had, like, if your TST looked like red and inflamed instead of indurated, you know, if it didn't look like true induration. And sometimes people do have reactions and they might, you know, they turn red early or something, looks a little different, but we actually have a decent number of kids. I call them kids because my oldest is now 17, but you know, still some colleges and nursing schools will require a TST or quantiferon to go into nursing school, or sometimes just college. And so someone who's never left the Cincinnati area gets a positive TST or quantiferon, and then their primary care physician refers this child to us who has nothing, like never been in a nursing home, never been in a jail, never left the country. And they're telling me like, it's impossible, I can't have TB. And we just say, we think it's not that hard to treat now. We think the benefit of treating outweighs the risk of it being a, you know, false positive. So definitely if it was someone who ended up in jail, I would assume that they maybe even had a few risk factors that maybe potentially, but who knows? There might be people out there with false positives, and that's our pediatric perspective.
So I have so we have 13 cases so far this year in Butler County. We've been very busy. One of them is a young woman who applied to be a CNA, and she's one of the Bhutanese refugees from Nepal. And so I have a documented skin test when she immigrated that was negative. So she was never offered when she was like 2.
Yeah.
In another state. And then she shows up at Butler Tech, and I think they did an IGRA. It was strongly positive, and she's underweight. And her main complaint when she went to the doctor was, "I'm having trouble gaining weight." Well, I'm not. She's actually TB, and she's gaining weight. We're treating her. She's gaining weight.
Yeah.
So you can have false negatives. I believe Mary Stapp has had this experience in the international adoption.
Definitely. That's why
children sometimes they come in, they're real scrawny, they haven't eaten for a while, they're refugees. But if you repeat the TB skin test later, it might be positive, but obviously it didn't have to come out.
That's why she gets 2 tests. They changed the Red Book recommendation because of her experience, where they recommend another one 6 months later after you're adopted. And then also she's told me she's seen a lot of negative quantiferons in kids who you know, definitely had documented positive PPDs. So I don't know, you know. So I think we don't have a better test right now, so we have to presume that it's positive until, you know, until we get a better test to be able to determine.
And I would also say, you know, like in a jail type of setting, you know, if they were to go on to develop TB disease, you know, then you potentially exposed all of these other prisoners. So just something to think about. Another tick in favor of treating the TB infection.
Yeah, I would actually say that the majority of our patients who we see who are not born in another country, who have positive PPDs and positive quantiferons, we cannot come up with a risk factor. Like we can't come up with any other reason that they would have it. And you know, we're asking grandmas with coughs, and you know, we're really digging deep to try to find some sort of exposure. And the majority we don't come up with one. Yeah.
Thank you.
But if we have other people from other countries coming in with the disease, that could
it makes sense that there would be more. Yeah,
it could be your exposure there.
Absolutely. I think, I mean, as we continue to see, I mean, the current trend suggests that we're going to keep seeing more tuberculosis, active tuberculosis. And so therefore there might be people exposed in ways that, you know, are not anticipated. You don't have to be in a jail. You don't have to be, you know, in a specific setting.
We have some direct messages in the chat. Chris Bordeaux would like to hear more about patients that can't tolerate the medications that need to be treated. What tricks do you have up your sleeve?
chaser. We like chocolate syrup chaser. That's a big one for us. Because I feel like when you add the flavors in, it's always like some fruity flavor that's a little sour, adding to like a bitter medicine, and that usually doesn't go well. So we tell them to try to get it down and then give them something else so they don't spit it out. And I honestly, it often takes two people with little kids. Like you have to, like a dog, unfortunately, like you have to like hold it down and hold the baby down and make sure they take it. And yeah, it's not always easy.
Unfortunately, from an adult perspective, we have a lot of, you'd think that they were acting a bit childish.
Not just a pediatric problem.
But I mean, Christine to Lucy, and I tell you what, Christy, you want to give a little insight to a 16-year-old?
Yeah, they're the worst. I know.
Yeah, I do have a 16-year-old that actually had that problem. And she is actually MDR, so she's on second line drugs already. And the second line drugs have, in the beginning, for probably the first month or two, every time she would swallow it, she would immediately vomit. Like
I know this patient. Yes, yes.
So she, I even brought in pharmacy and other nurses trying just to figure out what can we do. Because she wasn't just gagging, she would full-fledged vomit no matter what she had in her system. She's gotten it down pretty good now with putting some of her pills in yogurt.
Yeah.
And swallowing it down with the yogurt. But her bedaquiline, she actually takes a full mouthful of drink and kind of closes off her throat and pulls the fluid in there, drops the pill in, and then swallows. In the beginning, it was taking 20 minutes to take her medications. And we were doing in-person DOTs for that. So we literally would sit in the clinic for 20 minutes and vomiting in trash cans and everything else. But after, let's see, that was March, probably, we now are down to 2.5 minutes for one, and then actually less than a minute for the bedaquiline.
And I think she was legitimately feeling really terrible. She lost a lot of weight and she was having a lot of symptoms with her TB. So she actually looked really terrible when we started medication. And so I think, she probably is gaining weight and feeling better in general. So that's helping. But the other thing, we use the yogurt, but we have chocolate pudding in the clinic. So our 3 HPs, we have like a bunch of waters, and then we have several things of chocolate pudding, because it does seem like if they put something else with it in their stomach, they seem to tolerate it better. Yeah.
And she said apparently somebody at the hospital told her that sniffing alcohol pads helps.
Not us. I know, it's like I do. Yeah, it's super weird. I was like, what's that?
That's very common.
I have never heard.
I think
To make you not pass out, like smelling yourself.
Right, she like 5 alcohol pads for one setting of taking meds.
Dr. Hazel.
We literally had a video of her she was sniffing so hard on it. Her breath was actually holding the alcohol pad to her nose, and she wasn't even holding it because she was sniffing it so hard, thinking that it really was helping.
I'm not sure I condone that.
that would not be a good idea.
She's not doing that anymore. That's every once in a while, but for a good 2 or 3 months, I was kind of concerned about her. And she was saying
we
she
were
was getting
too.
addicted to the alcohol.
Yeah, we were worried about her. She was very,
For older adults, usually I send them home with a little Zofran. I tell them to eat something before they take their meds. There's this strong belief in a lot of, particularly my patients from Sahara and Africa who come in with positive testing, this is related to tuberculosis. So it's only like 2 or 3 pills, or if they're doing 3 HP. That's a different story, but there's a strong belief system that you must take medication on an empty stomach, and it was just messing with their stomach. So like, eat something beforehand, they'll be fine, or like putting it in porridge.
That's hard.
Nikki, do you have any other tricks from your side?
Oh, well, the one of them putting the liquid first, we talked to her about that, because that seems to help with my daughter, that's what she does.
But I can't put sugar in my mouth first and drink after. So I have to put it first, drop it in, and so that's just, and it needs to be something out of water.
That's how I always take pills. That's how I tell my kids, water and pills, and then.
So do you like
You had
take a
water
drink
goes
and then
to the back
throw
of
it
your
in?
mouth.
Yeah, you like hold it in your mouth.
And open, drop it. But capsules, you need to put your head down, pull forward, so it goes to the back of your throat, yeah. Now, capsules don't do it this way, because it's gonna float up, you'll swallow it, it gets better.
Right.
So capsules, pull your mouth and have the capsule in it, and go back and then swallow.
We also have some luck with those. I'm forgetting that you can get them on Amazon and they're called it's a special cup that you put the pill in the back of it and it forces it back as you're drinking. It's called I know I forget what it's called too, but we've had some luck with those, and especially teaching kids when they're 10 to 12 and they're like, it'll be a lot easier. You can take a pill, and so we'll try to like tell them to practice with Tic Tacs, and then like move up to an M&M or something. Try to practice with some candy at home so they can get used to it. Yeah. But.
And what about for individuals who, it's not a pill issue, but it's a side effect issue, so they're feeling terrible, they take the meds, they're having GI issues, and they can't keep going.
We would check their liver enzymes, look for hives, look for, angioedema, look for allergic reaction, and then you have to stop everything and sit on your hands for a little while till they're feeling better and introduce one at a time. There's a nice protocol from it's in one of those multi-drug resistant TV. One of those big guides from the Curry Center has a really nice chapter about what to do if someone's allergic to a medication, and I encourage you to look at it instead of going on the fly.
Yeah.
Don't just stop one and then add it back and it didn't.
Yeah.
You can be really confused about what causes size if you need too many starts and stops.
And I would say actually the one that we end up on, I think the trickier ones are often the rifamycin. So, there are more interactions, and some people really, really hate the orange urine and the orange tears. And some of these big sweaty teenage boys, and I'm sure you guys with your smelly grown-ups, they get very just kidding, but yeah, they I'm a smelly grown-up too, right? But anyway, I feel like isoniazid paradoxically is a little bit more tolerated than others.
It's more tolerated than others, but even if you explain to someone, please come in if you're not feeling well, even if it's between picking up your meds. I remember a lady, she bought Tums, and then she bought Zantac, and then she bought a lot of PPI, and then she comes to pick up her meds saying, I'm feeling really crummy, and her transaminase is up. So people don't always get the message. If you're not feeling well, if you lose your appetite, if you're just not feeling good, please call us. These medicines can have some.
And we've had several recently who have stopped taking it because they feel bad instead of telling us, and then they just stop taking the medicine, and then I'm like, well, we would have liked to have known, because then we could have talked about other options and checked, but sometimes they do feel bad and don't want to take it anymore.
We have had a few patients who it's clear that they have an underlying diagnosis of reflux disease, but they have not been treated. Then, they start taking some treatment for the anti-anti medications, and then things get much better.
One of what I want to say, one of the common side effects we have gotten with, especially, and maybe the physicians who are in the room can maybe explain. It especially happens to women that after taking the 3-HP, which is the isoniazid and rifampicin, for 12 weeks, they feel tired the day after they take the medication. And that usually resolves, maybe by the second day afterwards. Is this something that is of concern? Why does this usually happen to mostly female patients? Any comments on that?
Well, in my experience and what has been reported, well, is that seems to be part of that spectrum of flu-like illness kind of reaction that tends to happen either the same day that the patient takes the medications or up to the day after. Now, when it's a side effect like that one that is manageable and it's only 12 weeks, then usually patients are okay with that. But then when it becomes more of a, we have patients who may develop a fever or become dizzy and they go to the emergency department and they have hypotension, low blood pressure, then we have to stop the PHP treatment. Yeah. And again, it's not very well understood. Is some people will just develop that reaction, some others won't. But yeah, it could be the medications. Yeah.
I think the National TB Controllers Association has a nice guidance, like a PDF for how to deal with that. And one of the hints that they give is that, well, if it only was a couple of minutes, the first day, but then it was a couple hours a week later, and it was longer than that, that's a risky situation where you might want to tell them, gee, if you're feeling dizzy, don't take any more, because it seems like this is developing.
Right. Yeah.
We'll try that guidance for you guys. I think.
Yeah.
And I thought, I remember not making this up, that it was like women, like younger women tend to experience that more.
It seemed like it when we're doing
More
our
with robust immune systems.
Dr. Striker, you have a question? Yeah.
Yeah, I'd just love to hear what everyone does, given this burden of side effects, particularly in clinics that don't have quite as good pharmacist nurse support. What's the interval at which you recommend physician or APP visits during a tuberculosis infection treatment regimen?
Oh, we don't have a clinic. I'm not in a good position. I mean, we refer back to primary care, but the Butler County it's in an over 100-year-old, the Board of Health is in a 100-year-old bank. And we're down in the basement. So we have very minimal clinical support and we don't schedule follow-ups. We try to make sure there's a primary care. Okay. Fortunately.
I mean, I think, we're fortunate here at the clinic because a lot of times the pharmacists will ask them because they get a 1 month supply. And Nick, you'll ask them, like, are you doing okay with this medicine? So maybe depending on the patient and if I think they're gonna have a concern, sometimes I might bring them in a little bit sooner, like once a month or something, particularly if they have, other liver issues or something that I would be concerned with. Maybe I would monitor them a little bit more frequently. Or, maybe you could do like a video or telehealth, or, just to reach out and say, you tolerating these medicines okay? Or
So for the refugee population that I would see over at the Cincinnati Health Department, from ECP perspective, they kind of expected to come back monthly anyway. And a lot of this was diagnosed on their initial examination with me upon their entry into the country. So I would just see them monthly. If I was very worried about education, or somebody who didn't have high level of health literacy, I might even bring them back in a couple weeks, especially if I didn't get the sense that they may have absorbed all the information that we talked about. And often it's from a PCQ perspective, it's a really good check-in to say, hey, tell me a little bit more about how you've been feeling. Also, let's reiterate some of this education about how infectious TB infection can be as it progresses. And are you taking your medication as prescribed? And how are your side effects? And it gives me more touch points because I often end up checking liver enzymes for folks who are saying, oh, I'm not feeling great and I'm considering stopping the medication. And just for a lot of folks, they feel better saying, oh, the physician did something or the APP did something to say, hey, like, we're checking this is fine, maybe let's try some of these other efforts.
We have a question in the chat here. If you have questionable or indeterminate PVD and recheck too soon, can it give boost response and cause false positive?
So traditionally, the boosted TB was for the situation like if you were going to stay in a nursing home or you applying to work in a long-term care facility. You would place one TB skin test that if it was negative, you would just, say, we need to do another one because the first one may remind your immune system that you were exposed to TB when you were a kid. And unfortunately, that's as scientific as it gets, because if someone was exposed more recently, it takes 2 to 10 weeks to get the reaction. And so there's a lot of uncertainty, but appreciate the concern and indication.
In addition, how much does latent tuberculosis treatment reduce risk of getting TB in the future?
Yeah.
Studies in general have shown that the risk is reduced from 60 to 90%. So there is no treatment that is 100% effective, right? But getting to 90% is really good. It's the best we have right now. Now, the range of 60 to 90% comes really linked to how compliant the patient may be. So the more compliant the patient, the studies show that the highest benefit the patient will have. So the risk can be decreased at that 90%. But that also reminds us that even after TB infection treatment, if we have a patient who comes with symptoms of active TB, there can still be active TB. They may have been re-exposed, or maybe for whatever reason the prevention treatment didn't work, or they may have been initially infected with a strain that was resistant to the prophylactic regimen. So it's very effective for sure. But if someone who has been treated has symptoms of active TB, we should still screen them for active.
So while there's silence here, in response to the cups that are available, Jill suggests Peel's Taker's Cup and Sippy's Sure are 2 types of cups that are used at Cincinnati Children's Health Medical Center, and they're very helpful, especially for teens. So if you're looking for tips, those are these 2 that are for sure work.
Dr. Schlotter, how if often would you need to maybe put a G-tube in to the patient?
Oh, I don't think we've ever had to do that I'm aware of. So thank goodness. You mean like an NG? Yeah. I can't think of a particular patient, but probably the patient we were just talking about earlier was about as close as we got to that. And I honestly think a lot of the times, we have options with crushing pills and liquids and other things that we would try all those things first. Yeah. But it is a different situation if it's an active TB case where, if they're acutely ill. There have been a couple of those where, initially they needed a lot of help getting the medicines down when they're quite in the beginning, but usually they can transition.
Awesome questions. Online and in person. As we're heading to wrapping up, anyone have any final questions that we have for our team panel here, experts?
The panelists can question.
Yeah.
So is anyone screening poorly controlled diabetics who were born in other countries for TB preferentially? So we should probably think about it. We should probably think about starting. In other words, a lot of times people that come from other
countries, they might not be able to get health insurance for 5 years. That's a discouragement to taking care of your diabetes. It might be hard to find a physician. And if you were able to intervene and screen for TB, you may end up having to treat their diabetes at the same time and look for drug interactions between your rifampin for 4 months and your diabetes meds. And then what kind of resources are you going to use to hand them off to the community if you don't really have a clinic? But I think we should think about screening diabetics, because there's a lot of barriers to getting good diabetes care, and having out of control diabetes is a big risk factor for reactivating TB for people who come from other countries.
You know, just a comment. So with so many people, for one reason like more immunosuppressants and getting it. I'm surprised more aren't actually.
It's still a decent number of our, it's still a decent number of our patient population at Children's Now. Granted, you know, pediatrics is smaller, but it still makes up, and you know, we're a pretty big referral center, so we have a lot of kids coming from, you know, a fairly large radius, and yeah, it still makes up a decent chunk, but a lot of those are, they don't have any risk factors for having TB, so it's always a bit of a conundrum, and we always decide it's safer to go ahead and treat them, and we recommend treatment, but yeah, sometimes they're not super excited about it.
I had a funny situation where Dr. Woman and I were working on a TB study looking at TB infection versus controls, and they had to match in certain parameters. And so I had a family member come in as a match for one of my TB infection patients, and they tested positive for TB. And so we ended up getting treatment and all of that. It was kind of fun to see this progress from the inside. And of course, Dr. Hacker pulled up the map of all of these countries, and everyone's like, yeah.
And I will say for all of those, like the TNF alpha inhibitors that people are on, my infectious disease hat would say, you know, we do live in histoplasmosis country and blastoplasmosis. You know, a lot of those have the same symptoms, you know, that tuberculosis has too. So I always kind of think about that also. In those patients.
We have a teenager on our service right now who came in, you know, with acute lymphadenopathy, weight loss, et cetera, and yeah, they definitely histo and TB are the top of the line. The quantiferon was negative and the histo was positive, so it looks like histo won this time. But yeah, there is definitely a lot of overlap.
So yes.
Speaking about diabetes and TB, do you have majority of the patients you see coming from other countries? Are they coming in already diagnosed with diabetes, or are they get diagnosed here?
And, you know, a lot of times they're showing up as acute cases 3 or 4 years later. So maybe.
It's difficult. I know I'm from Nigeria, and certain diseases in other countries, it's hard for people to accept that they have it. A lot of things are, you know, they go to church, pray through it. We had a family friend that had diabetes, even getting amputated. I mean, he still was in denial. So I was just wondering how you communicate with them about getting it under control, or if they are accepting that they have it. And
I think that's a good question for the primary care. It's a very difficult disease to take care of.
There's a lot of patients who, my primary population was almost all folks who either immigrated or who were refugees. And it is very difficult. Often they were either hearing diabetes for the first time because I'm getting urine on them, and we're seeing a lot of polyuria, or I got a BMP and the glucose is in the 400s. So that can be a really lengthy discussion and can take a while to kind of get people on board with properly taking medication. And there's also other folks who are like, yeah, I heard that I've had some extra sugar in my blood, but then hadn't really followed up with the physician due to resources or other reasons. And having difficulty also saying, hey, like that is still a problem, just because it once was a problem doesn't mean it goes away, and just kind of emphasizing to patients who maybe either have different health beliefs or have lower health literacy, just saying, I mean, it's similar between tuberculosis and diabetes. It's like, it won't go away unless you take your meds.
And they're two epidemics that are overlapping, I would say. And,
Right.
I have a question, more for the person who's from the Justice Center. What treatment do you offer for latent tuberculosis?
It would be the same. That's available.
Okay, so you,
Yeah.
all right, it's available.
Yeah.
Okay, wonderful.
We do. Yeah.
Thank you for all the work you do.
Thank you. Thank you. Now, do you guys, so obviously there, then you guys give the medicine home, so you don't have to do anything else. Right. And taking it. Right. And once they're released, we would give prescriptions for them leaving, because they don't always follow up with primary care. So depending on the situation, if they have a plan to follow up, we'll give 30 days, but if they don't, we'll give it to them.
And then we see the juveniles at Cincinnati Children's, and they come with a few escorts with them. And they come and see us every month, yeah.
Is there an opportunity to think corrections and Hamilton County Public Health for when those patients, when those inmates are released?
Yeah,
Because
and
we could. Right, you don't have to go to the pharmacy to.
yeah, and I actually got in, that's why I'm here today, because I got in communication with Kate about it. I'm very close communication with Todd for our syphilis and that kind of thing. So, and the more that we build a relationship, the easier to get people.
Actually, that gives a good introduction to the rest of the staff in the clinic. So I wanted to take a moment to introduce some of the case managing nurses who and individuals over at Hamilton County Clinic area who take care of these patients and monitor them closely. We have Ms. Eva Mose here. She's our public health guru. She is Eva is a captain in the Army. Has her master's in public health, and she will actually be she is going to be deployed to Europe to be helping in a public health setting in December. So much as we are sad to see her go, we are so proud of her to see all the things she's doing. We have Christy Myers in the back. She is our she's got some pretty tough cases, including a mom baby scenario. And that was only one of many pediatric cases that have found Christy. So she takes really close call there. Amy Ellis is also on our team. I recognize her. She has been in public health for got it. Two when I started. I know. I'm the youngest in the bunch and I'm still learning. Got it. Right, long time. But she is a wealth of knowledge when it comes to public health in all genres of what we do, not just TV. We have Nikki Hopkins, who is our amazing pharmacist who just helps us through literally everything, organizes can be, tells us exactly what we need to know, keeps us in check with. Have you talked to that patient yet? We're like, yeah, no, we'll call her today. But it keeps us on top of it. So Jill Gass is on here too. She's our
Sorry.
You know, sometimes your voice sounds a little weird on video. I'll watch this back and be like, oh, yeah. Jill Gass is one of our CMPs, especially for STI Clinic. We have Amanda back there who's our other CMP, who helps with our cases, among other STI training. And Eva White is our director of nursing. So lots of stuff. And Ann Arpel is here too, and she does epidemiology portion. So a lot of whenever we have individuals call in from the community asking about recent LCBI rates or I don't know, and with another hot topic that's been coming in through. A lot of school nursing and yeah, right? They all are calling in, we direct them directly to the stats line. We're like, oh, hold on 1 second, let me get an MD on for you. So we have awesome communication.
If I could just say congratulations to you tonight. This has been a passion project with me for many, many months.
We can take a picture. You there? Don't stand up, sit down. Don't stand up. Yeah. Yeah, perfect.
Yeah, that seems bad.
Thank you so much for your.
Yeah, thank you, everybody.
Yeah. That about wraps it up. Thanks everyone in the chat as well. There's the code, if you don't mind, in the pamphlets that we passed out, we have, I'm so sorry. Dr. DePere is also here with us. I do feel like I am part of your Amy, but so Dr. Swan is with us Tuesday, Thursday, Dr. Williams, and Dr. DePere share Wednesday slot. So they take, oh my gosh, the patient that we've seen today, Dr. DePere, has been able to help with some strict conversation about patients and active GP disease, taking their medications, understanding the guidelines, understanding the rules. And she's also our NIOSH guru. I keep using it now, but if ever we have a moment for contact investigation where we feel very unsure in a facility, if who would be in that concentric circle of low, medium, and high risk, my go-to person is to call Dr. DePere and try and get a good layout of who might fall in that risk category. So we are so grateful to everything she does. Okay, now we do have a feedback evaluation for anyone who'd like to take it, so it's optional. Please don't forget the CME portion of the continuing education is also in the pamphlet and in an email I sent out. The pamphlet does have a QR code. So scan that and that should lead you directly to the site. If you need more directions, should be in the email I sent. If you didn't get that email, I'll send that to you by Friday. So be on the lookout for it. Your question is that survey not working? It's not. Okay, so that happens in technically. I'm lucky I got this far.
90%.
I'll send out that QR code later. But it's good feedback on how this is going, and hopefully we can turn this into a quarterly series with multiple different topics varying from other physicians. Maybe talk about TB, the morbidities, and also maybe grasp from the nurse perspective of individuals who are in Hamilton County from migrating areas and how that plays in. Elin gave a fantastic presentation at a recent all-staff meeting regarding patients from Martinia. So that was super helpful to give an idea of all the patients that we work in. We're hoping to continue that process. So thank you all for participating, and we'll see you next time. Yeah.
Yeah.